our next speaker has the first-hand experience that comes from being in the treatment provider community. Zach Talbott is the director of the Tennessee statewide and Northern Georgia chapters of the National Alliance for Medication-Assisted Recovery, NAMA, and is a certified medication-assisted treatment advocate. He served as the administrator of the MARS Medication-Assisted Recovery Services Project's Peer Recovery Network and was funded by the U.S. Substance Abuse and Mental Health Services Administration to develop a model of the MARS project that would provide recovery support and services for methadone and buprenorphine patients in rural areas of the country.
So what I'm going to give today is more, we don't have a lot of data. We have some out of Shelby County that was just presented, but it's more of the subjective experience of what we are hearing and what we're seeing from patients on the ground. With NAMA Recovery, NAMA Recovery is the premier or the largest advocacy organization specifically for methadone and buprenorphine patients in the nation, arguably in the world, with several international affiliated organizations and over 30 chapters in this country. So when methadone patients or buprenorphine patients, people that are seeking treatment, active drug users, have a problem, they tend to turn to NAMA. And so we see a lot, we have a big connection with the active using community as well as those that are in treatment and that are living in recovery. And so when this law was first proposed, we had a lot of initial fears that women who were in treatment, methadone maintenance, despite all the controversy, is the standard of care for pregnant opioid-dependent women. The National Institutes of Health has made it very clear that it's the gold standard treatment for all opioid-dependent people. And the Centers for Disease Control and Prevention has gone further and even said methadone maintenance specifically is the, quote, most effective treatment for opioid addiction. And so when these women are seeking what is the known standard of care, and now we're starting to see that buprenorphine is coming in a close second, though we don't have near the decades of research for it that we do with methadone. It is, as some of the speakers earlier today have alluded to, it is possible that the children can be born with symptoms of drug dependence. The law itself is poorly written. It speaks about babies being born addicted. A baby cannot be born addicted. It is not possible. They can be born physically dependent. But addiction, if you look at the definition of addiction from SAMHSA or any other authority, addiction entails physical dependence and then a whole other host of things. And so the law, first of all, speaks of babies being born addicted, and using that type of language further stigmatizes the drug-using community, drug-using women, those that are living in recovery that aren't using drugs anymore. So some of the wording was bad. But what we were concerned is that women who were enrolled in the standard of care, the treatment that is most recommended for them in their condition, if their babies upon delivery experience neonatal abstinence syndrome, that these women would then be prosecuted under the law. That was our big fear. Thus far, we are not aware that that's happened, but the law is written as such that it leaves a lot of leeway for individual prosecutors, and so it still could happen. There was an Amendment 1 to the law after it was originally passed that tried to alleviate some of these concerns. Originally it was Amendment 1 to Senate Bill 1391 the governor signed it, and part of that was to try to assure that women who were enrolled in treatment would not be prosecuted under the law, but again, they didn't turn to the experts when they wrote this, and the wording, again, is very bad. It talks about women won't be prosecuted when they use language like the completement of treatment. Maintenance treatment, how do you complete ongoing maintenance? And so there's still, even with this amendment number 1, the fear that women who are in the standard of care can be prosecuted under this law. That's still a very real concern of ours. And so we had, other than that, it criminalizes addiction and pregnancy outcomes for the first time and provides absolutely no funding for treatment. You're going to potentially put women in jail, but there are no funds, there's no resources that have been allocated under this bill for treatment. We've not seen the expansion Specifically, in the first months after this was passed, there was some data presented earlier that talks about treatment admissions had gone up for a few months, but not to the standard of care. These are not treatment admissions to the standard of care for pregnant opioid-dependent women, which is maintenance treatment. And there's no funding for that. So those were our initial fears. Thankfully, thus far, we've not seen women that I'm aware of that have been reported to us prosecuted that are actually enrolled in treatment that are free from illicit drug use. But what we have seen on the ground is, I'm going to give you a couple of specific examples of women that our chapter of NAMA has worked with or spoken with. There was one specific pregnant patient, or not, she wasn't a patient, excuse me, a pregnant woman in eastern Tennessee, and she was buying a maintenance medication on the street. She was scared to go to treatment because of this law. She was scared. We tried to explain to her that with confidentiality and other things, the treatment center is not going to turn around and report her, but that what this law has done is generated a lot of fear in the pregnant opioid-dependent population, the pregnant population in general, I think, in the state from what we've seen. So she remained buying maintenance medications on the street. She lived just right around the Cleveland, Tennessee area, which those of you don't know is just north of Chattanooga, Tennessee. And she went into labor and hopped in her car and got on Interstate 75, trying to get across the state line before she delivered. She did make it into Georgia and ended up delivering on the side of the road. Mother and baby are fine, but you can imagine how tragic that could have turned out. Not only that, the baby, because she was taking maintenance medicines illicitly or off the street, the baby didn't get any of the care that it needed after. So there's a lot of complications. If not for this law, this is a patient I'm confident would have gone to an opiate treatment program and would have been getting proper maintenance treatment, prenatal care, and then the baby upon delivery would have gotten proper treatment as well. We're also seeing pregnant women. I know we've heard of at least 2 in the Knoxville area where there are a couple of opioid treatment programs that provide standard of care treatment for pregnant women. That are driving more than 2 hours one way to treatment because they're going out of state for treatment, because they're scared if they go to treatment in state, they're scared to be prosecuted under this law. Wouldn't be, risking themselves driving over 4 hours round trip daily for the first several months, every day making that trip. No one should have to drive 4 hours a day to get the standard of care for their health condition. So we're seeing that. We also have known of at least 2, there's 2 patients that we've talked to. One of them, we know the outcome, we're not sure what the second did, where they were, like many single women, they were wrestling with the decision about their reproductive health and did they want to carry to term, did they want to terminate their pregnancy. This is a very personal thing that these women were wrestling with. They were opioid-dependent women. And when we spoke to both of them, they were both wrestling with, am I going to carry to term, am I going to terminate? These are things that they would have likely been wrestling with as a single low-income woman anyway. And we know that at least one of them chose to terminate, which is her right, but the reason she chose to terminate her pregnancy is because of this law, because she was scared that even if she were in treatment, she would be prosecuted under this law. So in a state that has a supposedly pro-life culture, this law is, from what we can see, resulting in more abortions. So those are just a few examples of what we've seen. I encourage everyone, I think this law has got to sunset. It's discouraging women from going to treatment. It's encouraging women who may otherwise not have terminated their pregnancies to terminate their pregnancies. It's causing women to have to drive hours and hours out of state. It's causing women to have to deliver babies on the side of the road. All the while we're trying to deal with a medical This is a medical and a public health crisis that we're dealing with here. We cannot solve a public health crisis with a criminal justice system response.